Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you, and mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. Good morning. And this is Dan Gaddis, and thank you for tuning in and sharing the morning with us, being a part of this morning's program. It's Monday, September 13th already, almost halfway through the month. 70 degrees here in uptown Kingston, and we'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5. Thanks for starting your day with Kingston Community Radio on
Moms, we don't know how you do it all, but you do. You are part teacher, counselor, chef, and doctor, all rock star. Being a mom today is complicated and sometimes unpredictable, but it's those precious moments that make your journey together crazy and wonderful. At the American Heart Association, we know your family is why. That's why we're here for you, to make sure more of those moments happen. To make sure a healthier, longer life is possible for you and your family. We're impacting laws that help shape healthier communities, but we can't do it without you. Moms are at the heart of change. So here's to you, Mom. Here's to impacting the health of our future. Moms United can make real change. Start by visiting lifeiswhy.org/moms, the American Heart Association, and the American Stroke Association. Life is why.
Hi, this is Anne Marie from the great town of Kingston, and I support Kingston Community Radio, and so should you.
And thank you for being with us here at KCR, kicking off the week, and every weekday from 7 to 9 a.m., you are with us here at KCR on 92.5 FM, AM 920, and streaming online at mykcr.org. 331-9255 is your call-in number, and today is a Medical Monday with Dr. Eric Stamberg. And let's get to the on-air studio with Dr. Eric Stamberg and his first guest.
All right, my first guest. All right, welcome to this morning's show. I think it's been a break here. I think we were last year 4 weeks ago because we had 3 weeks off. We had, right? It was, I lost track. We do the first 3 Mondays of every month, and August was a 5-Monday month, so the 4th and 5th, and then there was Labor Day. So now we're back after a month. I'll be here from 7 a.m. to 9 a.m. I am here in a very crowded studio right here. We got Ms. Robin Baker joining us.
Good morning.
Everybody's favorite conversation facilitator.
Correct.
To give us the voice and perspective of the lay person.
I don't know about that.
So I don't get too jargony.
Yeah.
And then also we have a guest, our medical student for the month is a young doctor of the future named Thomas Richter.
Hello. Nice to meet you.
Thomas hails from Pittsburgh.
Steelers won last night.
They did, yeah.
You follow football. You said you didn't,
yeah.
you didn't care about the Pirates. They're kind of lame.
Yeah.
They weren't supposed to win, but they did.
Yeah, they
Pittsburgh.
did.
Yeah. Good game.
All right, so we'll be
Go
here from
Stillers. Go Stillers.
Yes.
All right. Are you from Pittsburgh too?
I'm from Pittsburgh too, Tom.
Oh, look at that. I forgot he was from Pittsburgh.
Yeah.
There we go.
And is our friend Chris from Pittsburgh as well?
Shout out Christopher Nedden.
Yes.
Great win.
Is he from Pittsburgh, or is he just like Pittsburgh?
He just loves them.
All right.
Like is not the correct word. Yeah.
All right. So we'll be here from 7 a.m. to 9 a.m. to talk about various medical subjects. And first, I just we'll have a little conversation with Thomas. What do you think?
Can't wait.
All right. So, Thomas, you are now in the 4th year of your medical education. So just for people to understand, medical school is typically, or is, a 4-year school, usually after college. Some people do a combined program with their college years and their med school years. That could be a 6 to 7 year program. So you're in the 4th year. So this is I remember really enjoying my 4th year of medical school. As a matter of fact, being the first time I think enjoyment in medical school entered the same sentence for me. But it was really a time when I started to say, hey, I'm going to make it. I'm going to be a doctor, and getting to kind of be motivated from inside about, learning things rather than just kind of like, got to study for a test, got to do this, That's what we call internal versus external motivation. We all strive for a state of internal motivation.
Yes, we do.
See how much she contributes to the conversation? Anyway, so what do you think? How's your 4th year going so far? What are your thoughts and your opinions about overall how things are going for you as a doctor of the future?
So, yes, I agree. I would say the 4th year is definitely a lot more of what I would say internal reward, because really you get to pick what you want to do. So 3rd year, I'm doing core rotations.
Right.
And, it's good to get an experience from everything, but it's nice in your 4th year to sort of decide what you're going to be doing. So, for example, I'm going to be applying to radiology, so I got to do more rotations in that. And then I'm doing family medicine, which I also really enjoy. So, yeah.
All right. So, yeah, Thomas has chosen to go into radiology. He likes to be in the dark. But you better double up on your vitamin D now, because you won't have much sunlight in your future. But anyway, yeah, so this is exciting, And I remember in 4th year medical school kind of like being like, I'm ready, and everyone's like, just relax. You're going to be a resident before you know it, But it's exciting. So he's starting to apply for residencies. Quite simply, what made you kind of choose radiology? What is it?
Sure. So I would say that compared to a lot of medical students, I'd say I'm probably a little more introverted. So kind of enjoy sort of the idea of radiology. You come in, you have a task, list for the day, and it's just kind of like solving puzzles on your own. And I really like that. Everyone said, if you liked your first 2 years of medical school the most, which I did, which is probably bizarre, then maybe radiology is for you. And then I tried it, and I really like it, yeah.
A lot of people don't realize radiology is, a lot more than just X-rays. There's CAT scans, MRIs, ultrasounds, and a lot of what they call interventional radiology. What would be some examples of interventional radiology?
Interventional radiologists are the ones who can maybe show you almost like an X-ray in real time. They'll do like fluoroscopy, so they'll put in some dye, and you can actually see what's going on in the blood vessels, and maybe they can put a stent in.
A stent, like open up a clogged blood vessel.
Yeah.
Right. So it's a lot more than just sitting in the dark looking at X-rays. I gave Thomas some advice. I said, remember, Thomas, you're going to have a guy like me order this test, and you're going to look at it going, just remember, it's just me on the other end trying to make sense of it. So we'll work together on it.
Yeah, they make sense of stuff. It's great.
Not to rub it in, but the digital era has been kind to radiology, because, the fact that, they can kind of work from home with the appropriate equipment, and, it's been all right, and he could, next thing you know, maybe in 10 years from now, he'll be in a boat in the Gulf of Mexico reading X-rays or something.
It's a lot of advancements, right? I mean.
Yeah. Technology is getting just exponential.
Yeah.
So Thomas hails from Pittsburgh, and what was like your main motivation to go into medicine?
I think a lot of students have like that aha moment where they say like, oh, now I want to do medicine. And I feel like I'm maybe a little more unconventional. I was a music major, so didn't really have, all the prerequisites. I took some years off in between medical school.
Really?
Yeah. So I took about 3 years off, and I just was looking at a lot of different jobs, talking to a lot of friends. Ended up, working in the medical field as a scribe, and then just sort of realizing, oh, I like this. So
you worked as a scribe in an ER, right?
Correct.
So a scribe. You want to describe a scribe?
Sure. Sure. So to describe a scribe is basically the guy who walks around with the doctor and helps him write his notes, keeps him organized. So
It's an interesting discussion because the documentation world got more complicated. So the medical establishment was like, well, we could either simplify the documentation or we could just bring along a scribe. And usually it's a little bit of a deal. Scribes are usually aspiring medical students taking some time in between college. And, you soak in a lot, right? I mean, you're basically a fly on the wall. I'm rather opinionated. I think scribes are horrendously underpaid. It's kind of like, all right, you're going to accept this minimum wage while you pad your resume to get into medical school. But really, I mean, for someone who's entrusted with a, very important thing, which is the medical record, I think they're underpaid. So I want you to tell all your scribe friends, I'll give them a raise.
I think it's important too from a patient perspective too, because there's like a mixed reaction from patients. You probably find in the office too, because there's an extra person there. So that makes it a little more difficult for the patient. I think patients are like fine when there's a medical student, right, who's there and they're there learning, they're there observing, and so a patient feels like they're helping out, right? But when there's a scribe and they're just taking down everything that everybody says, and
a stenographer,
like a stenographer, right? I think, I don't know, it's something that maybe should be explained a little better to a patient, like in real time.
I think, and one of my colleagues over at our Kingston office uses a scribe in the office too. There's a very small percentage of time where the patient just has something so personal or whatever that the scribe gets asked to leave. But I think it's one of our problems and is continuing to make eye contact and talk to the patient and not allowing the computer screen to absorb us.
Yeah, we don't like that.
Right. So, I have I think part of my back problems is, Thomas has seen it. I literally twisted the whole day. I got the computer over here, yet I'm trying to face the patient. So I think the scribe in a way does that, because someone else is kind of writing stuff down. The provider, the doctor can make,
Look at the patient?
Look at the patient.
Amazing, yes.
When I refer a patient, and every now and then I'll ask a patient to give me some feedback on the specialist. Sometimes the patient says, well, they really just have their nose buried in the computer the whole time. And I feel that story makes me sad. I don't think that's the fault of the provider, the doctor. I think that's the fact of the way the computer is kind of an intrusive presence in the examination room. So anyway, the scribe is a solution, and it helps prepare a young medical student, to get ready. Try to get into med school. He took some time off. I didn't know that. Mm-hmm. I was a pre-med. But I didn't go right through. I took some time off after, so I was. It was a little analogous, but I didn't really have to do the courses. I just had to, make the case after working as in human services and social work for a couple of years to why medical. I remember trying to explain the connection. It's taking care of people, and having a little bit of a hard sell to a few of the med schools I applied to, who were kind of like, well, you didn't do any biomedical research here. What do you mean you were talking to people for a couple of years? So that was, but some med schools got it, but because I obviously was able to get into them.
Right, you were an English major, and Thomas said he was a music major.
Right, and I think there is a good tradition of physicians kind of in the arts or the humanities, and I think it prepares us, very appropriately to be physicians as well. That notion that every single med student has to be a biology major and has to get their name on some research project, write a paper.
Yeah, exactly.
Doesn't hurt.
What?
It doesn't hurt.
No, actually, I'm very impressed when I see resumes that have stuff like that. And I'm like, well, I wrote a letter to the New Paltz paper once, but I never got an academic paper published. So
now as a fourth year, you have to send out your resume and apply to residencies?
Yeah, and basically this next month.
So that's a risk, right? I mean,
yeah, no, it's pretty scary.
Is there like a lot of rejection involved?
Oh yeah, mostly rejection, I would say.
Mostly,
yeah.
It's got a little bit harder. I mean, there's more med schools now. Thomas goes to a rather new medical school in Middletown, Toro Medical School.
Yeah.
So there's kind of more applicants. There is a growth in residency numbers, but I'm not nervous that it's not keeping up with the supply of new physicians.
Yeah.
So some people are left out in the cold, and that troubles me, because it's a long road for young doctors, a very expensive road, and to kind of be left with nowhere to go when you're done with it. How upsetting do you think can that be?
What do you mean, not getting into a residency at all?
Yeah. And, it happens where someone has to reconsider their choice of specialty. Radiology is fairly competitive. Other fields, people want to be orthopedists, for example, and they wind up having to choose another field because they weren't able to get a slot, so to speak. So it's tough.
Yeah.
All right. Well, and do you feel like your medical education has done a good job of preparing you?
Yeah, I think so, definitely. And it was really tough this last year, obviously, because of COVID. So they were very hesitant to bring students in the first place. But first 2 years are kind of what you make of it also. I don't know if that's how you felt,
everyone's different, right? I remember enjoying my clinical years, a lot more. Typically, because Thomas is not normal. Your 4-year medical school is composed of 2 kind of what they call didactic years and then 2 clinical years. So the first 2 years you're literally in courses all day long. Very little direct kind of exposure. It's actually a valid criticism of our medical education system.
Yeah.
I'm still amazed at how much emphasis is still put on biochemistry, for example. And I think American physicians are undereducated with nutrition. So it's to me, biochemistry should become a nutrition and kind of wellness component of the basic medical education. And, I had to learn, I don't know if you ever heard of the Krebs Cycle. Have you ever heard of that?
I've heard of it.
Yeah. It's we had to learn it, Thomas probably as well, had to learn it in high school, had to learn it in college, and you had to learn it a third time in medical school. Just memorize this thing with these little components, and it doesn't mean anything.
Let's hear it.
Oh, I don't remember it. I don't remember it either.
Yeah, but you learned it 3 times.
I did, and that's to tell you. All right. Well, I hope Thomas is enjoying his exposure to the realities of my practice. I always tell all my students, you're gonna see it, the warts and all. You'll see the joy, the thrill of victory, the agony of defeat. Practicing primary care medicine. You remember that the Wide World of Sports? You probably remember it. They would do the credits, the thrill of victory, and then the agony of defeat. They showed some skier having this horrendous crash. So I don't know. I don't want to make that analogy to the office in my day. Sometimes
agony of defeat.
I don't want to be that skier.
It's not like a diabetic foot exam, is it?
That's pretty funny. No, that's a different type of agony of the feet. But we've talked about that. We've had podiatrists on our show. So we always want to talk about some bread and butter subjects. So actually, I have a sort of informal curriculum to our radio show. I kind of revisit general topics, because part of what we're here is to explain to people listening, various healthcare topics.
Yeah, and then we get lucky and get some callers, too.
Right. So what's our number again? 331.
9255.
Yeah, exactly. 331-9255.
All right. So I thought we would talk about high blood pressure, kind of a bread and butter subject. And Thomas certainly sees me treating that all week long, several times a day.
And I feel fine.
That's right. I don't want to know, Doc.
I feel fine.
So one of the nicknames for high blood pressure is the silent killer, because you do feel fine. It's unusual for a patient to feel that their blood pressure is elevated. That does happen, and that can be sometimes called a malignant hypertension or a hypertensive emergency. But you're talking, those numbers are really high, like 250 over 120. I'd have to fact check this, but I think our President FDR had a stroke in 1945, and it was clearly linked to high blood pressure, and his blood pressure at the time when he was evaluated by physicians was about that, 250 over 120. So that's what killed FDR in 1945. Anyway, it's always good to kind of put a kind of historical twist on things when appropriate. Anyway, so why do we care about high blood pressure? Do you want to begin with that answer? What's the big deal?
What's the big deal?
Yeah.
So I guess in simplest terms, the higher your blood pressure goes, the more effect it can have on organs.
On organs, right.
Heart, your brain, like you were saying, stroke. I mean,
That's right.
heart failure, things like that. So
That's right. You know, imagine a plumbing system, because in a way that's what our blood vessels are. That has the pressure too high. Eventually something's going to happen. A pipe's going to burst or whatever. So you're right. So it's a major risk factor for heart disease, heart attack, and also stroke, and then some other things like kidney problems. They probably tied for number one with the cause of people who need to go on dialysis is diabetes and high blood pressure, kind of tied for number one. And by the way, people frequently have both, so they don't have an additive effect. They don't add; they're exponential. When they occur on top of each other. They're visual problems, right? And things like aneurysms, which are also kind of blood vessels. So that also could be involved. Yeah.
I have two questions.
Yes, sir.
One, dystolic and the other one.
Diastolic.
Diastolic, yes. When did that become a way of measuring, and is that all there is? Is that actually all there is those two numbers?
Right.
Or are there other criteria or components to blood pressure monitoring that could be revealing other than those two numbers?
No, good question. Good question. You want to just give a basic summation of diastolic and systolic and diastolic?
yeah, so when they give you a blood pressure, say 120 over 80, that's like a common, that's like a baseline. Systolic is the top number, diastolic is the lower number.
Right.
And basically it's the pressure that the heart puts
Right.
on the blood vessel initially, and then when it collapses, and that's how it makes the systolic versus diastolic.
So systolic is kind of like the pump, the high point, and then diastolic is kind of like your general pressure. But there are other numbers that are sometimes talked about, like what's called the MAP is used a lot in like ICU medicine, the mean arterial pressure. But generally, in the outpatient setting, we just look at those two numbers. But there's a whole new category of how to monitor someone's blood pressure. And Thomas, has heard me kind of talk to patients about, maybe getting a good home cuff, the technology, very good home blood pressure monitors you can get for, I'd like to say $50, I don't know, over at any pharmacy. And the importance of getting some readings from someone at home when they're kind of at their baseline. People, I don't know if Thomas picked up on this or Robin as well, but the doctor's office can be a little stressful.
White coat hypertension.
Yes, white coat hypertension. Always blaming me for something.
It's all your fault.
So the idea of white coat hypertension is a real deal. And then kind of mixed messages, though, and Thomas knows this too. Where my computer system wants to know what the patient's pressure is in the office. Whereas I kind of want to know what they're running at home a lot of times. There's a whole new industry of home monitoring and a way for someone to send this data to the physician, and there's a way to that's sort of kind of paid for under Medicare and other insurance plans. But like any other thing, there's a lot of components to it that are complicated. But I received a note from a local cardiologist last week who, in the description, she said she was setting the person up with home blood pressure monitoring. So obviously, that cardiology practice was seeing some value in it.
Can you read your blood pressure on your phone?
No, not that I'm aware of. You can measure your pulse, and it gives you kind of a pseudo EKG sometimes on my watch. I'm not aware of any app or whatever that can measure pressure.
Yes, you can with your cuff.
Oh, with the cuff, right.
And with the machine that, there's a good German company that has one. We have one at home. And that can connect to a app via Bluetooth, which keeps the record of what there is.
But you need some sort of
you definitely need
right?
the cuff, yeah.
You can't just put your watch on and have it pick up your pressure. But no, I think that's important. I think it probably is the wave of the future, but I'm always a little cautious with new technology because, for one, it's costs something, and we have a problem with our healthcare system becoming ever more expensive, and this is one more thing. So in addition to costing something, is it going to really add value? So I want to see the evidence that this is going to, even though this is great and this is shiny and this is new, is it really going to help me, help the patients? Is it going to really improve patient outcome? I think the answer is kind of yes, but I'm also cynical about the industry hype around it too.
Yeah, no one said that it was covered by Medicare when we went to buy it.
Did you buy it?
Oh, yeah. We bought it, from
Was it covered by Medicare?
CVS. Nobody said so.
Right. It's a whole new, Medicare with great fanfare will announce that they cover something. But when you read the details, they're always like, well, but you have to do this, you have to do this, you have to do this, you have to do this. For example, Medicare for great fanfare covers depression screening. Okay. Well, it's what's called a time-based code, which is 15 minutes. Thomas knows most of my appointments are 15 minutes. So, it's just, unless I bring someone in just for the purpose of depression screening, it's kind of an unusable code. So even though they say they cover it, they kind of really don't, unless they want to redefine, what's being covered. It's a problem.
That's part of the wellness visit too.
It is, but it's right. It's part of your it's a required part of your wellness visit. That is true. So. And that's sort of when we do it, but it is on the books to kind of do it separately. Anyway, so back to high blood pressure. So we talked a little bit about the basic numbers, the difference between systolic and diastolic. I've been around long enough to know studies that said the systolic is more important, the diastolic is more important. The answer is they're both important, which is why we care about both of them. So what are the numbers that worry us? This is a good question too. How do we define high blood pressure? And there is a little bit of shifting goalposts going on with this. So what do you think? What would be the cutoff that you would want to tell a patient that they have high blood pressure?
So generally, I feel like systolic's usually easier to.
It kind of is, right? I agree with that.
It's usually more noticeable, I guess, early on. So I would say like 140 is probably already the area, and then maybe over 90.
Right.
40, or something.
Now, there's a poster in my examination rooms that kind of, tries to make a point that on the current guidelines, a systolic between 130 and 140 is also kind of considered too high. Now, a little bit of semantics. Is that hypertension? Is that pre-hypertension? Is that just elevated blood pressure at risk of hypertension? Even places like the American Heart Association, whatever, would define it as hypertension. That doesn't necessarily mean I'm going to tell someone who's got a systolic of 136 that we're going to put you on medicine. I can now kind of incorporate that as a focus on what we call lifestyle modification, which is really an important part of the treatment, whether it's the initial treatment or if someone needs medication, it's also part of the treatment. So what would be some lifestyle things you would tell someone?
Lifestyle. So, exercise, eat well, don't smoke. Smoking is also a really big proponent of
smoking. Well, because nicotine is kind of a stimulant, and nicotine is also an independent risk factor for heart disease and stroke as well. So again, that additive, that exponential of risk factors. 1 + 1 doesn't equal 2; it equals 4. And so on.
It takes you back to your initial. Even his comment, which is so, exercise, eat well, to your comment about medical school, kind of not concentrating on nutrition maybe as much as they should. Because, instead of having medicine, you're going to say, have good nutrition. So.
Right. And weight loss is very important. People, if the machine is bigger, the pressure might be up a little too high to keep it going. So lifestyle modification is weight loss. A good healthy diet, exercise, regular exercise. Salt is 1 minute to our break, but salt has always been kind of debated. What's the role of low salt? And I've read conflicting articles over the years. Salt makes you retain water, so if you retain water, your pressure is going to be higher. Kind of the opposite of a diuretic, by the way, which is a commonly prescribed medication. But if someone has that borderline or that pre-hypertension, I do recommend a low salt diet as well. We're going to go to our first break. We'll revisit this after our break.
Thank you, Dr. Eric Stamberg, Robin Baker, and Thomas Richter. Thank you so much for being with us so far today, and we look forward to our 7:30 half hour. You are listening to KCR, Kingston Community Radio, on AM 920 and 92.5 FM. My name is Dan Gatis, and it is 7:30 a.m. this Monday, September 13th, and 70 degrees right now here in Uptown Kingston, and we will be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage, anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
Hey, hon, what you doing with your phone?
Do flowers have best friends?
I don't know. Hey, look.
Whoa.
Some answers can only be found in nature. Discover the unsearchable. Visit discovertheforest.org to find a trail near you. Brought to you by the United States Forest Service and the Ad Council.
Part-time job, full-time hustle, all-time Shiro to all of us. Now it's time for you, our Shiro, to stretch for the stars. Get free tips to help boost your retirement savings now at aceyourretirement.org/Shiro.
Brought to you by AARP and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. And this upcoming portion of Kingston Community Radio is brought to you by Central Hudson. Little weather and forecast for the next few days. And with all those rain clouds going above us right now, I'm a little leery about this one here, a mix of clouds and sun with a high around 80. Partly cloudy skies this evening, increasing clouds with periods of showers late. A 40% chance of rain tonight, and it's a low of 57. Tuesday, mostly cloudy, and Wednesday, evening thunderstorms. And let's get back to the on-air studio with Dr. Eric Stamberg, Robin Baker, and Thomas Richter.
Thomas Richter. All right, welcome to the second half hour of this morning's show. Our phone number is, I'm going to say it right, 3319255.
It's getting so good, Dan. It's only been 8 years.
Mental exercise.
He has a mind for radio.
I had to move the Krebs Cycle out of my brain to make room for that phone number.
Exactly. It's not something you use anyway. So
yeah, the phone number of the Krebs Cycle. Anyway, all right. So let's. I say, when I think about this morning's show, I go for the first half hour we'll talk about high blood pressure. Well, guess what? We barely touched on the subject, and we're into the second half hour. But we have to approach this somewhat. So. We went over why we care, risk factor. We went over lifestyle changes. We went over the importance of being there. You should be screened for it. When patients, I say to patients, you should come see me once a year. They go, well, I say, look, even though you're healthy, we're doing a lot in this visit, and there's another whole component, which is also just kind of, picking up on other risk factors. As people get a bit older, they put some weight on, and then other things can come along with that: high blood pressure, diabetes, whatever. So it's the possibility, a potential for a physician to kind of intervene with that. It's a common criticism of doctors, by the way, that we don't care about wellness. We've heard that a lot, right? We want to keep people sick. What?
You treat sickness.
Yeah, we want people to be sick. That's how we make a living. Have you heard that?
It's not true.
Of course it's not true. So here we are going on and on about something that you don't know you have. And we want to identify and treat it so you don't get sick. So, all you got to do is think of one step further. That criticism of physicians like myself is really not valid.
These conditions just happen, or do patients bring it on themselves? I mean, the risk factors are different for different like ages, right, and different women and men, right? Isn't it different?
Well, we didn't go over the importance of family history, which is very relevant. High blood pressure does run in families, so that's one thing that's important, and that should be part of an interview. With family history is an important part of our any patient evaluation. As we get older, pressure goes up. One of the old-fashioned terms for high blood pressure was hardening of the arteries. Whether or not that's an accurate analogy or not, but the idea, it just makes the point that as we get older, the pressure will go up. I don't know if you want to think of it like that, that's fine. And then there's also some kidney changes that also lead to increasing the blood pressure. So it just becomes more common as we get older. All right, so if someone has high blood pressure, say it's like greater than 140, there's different degrees of how much greater. What would I do in the office? I would do a basic exam. Sometimes, not always, I'll do an EKG, right, Thomas? We dealt with that a little bit. It's probably not a bad idea if you have high blood pressure to have an EKG, and I think every cardiologist and most doctors will say that's part of your treatment. I don't necessarily do it at the first visit. Sometimes I feel like I don't want to scare the patient away. Some guy is coming to the doctor for the first time in 10 years, and we're all of a sudden like, got to do this, got to do that. And the guy's like, I'm not coming back. So sometimes it's kind of stages of induction. That's a bad choice of words, too.
Right, because people kind of go into denial, don't they, about this particular thing?
Right. They're like, I don't know, that's it.
They feel okay.
And that's a balance in primary care in general. When I'm trying to talk to someone about prevention, and then other topics might come up, like colon cancer screening. Sometimes I really ease the patient in over subsequent visits rather than just kind of brand new patient. We're gonna pounce. And that's something that's really not. Thomas will tell you it's a little bit of a frustration. It's not really bad. It's hard to measure. When they measure me, they're like, well, what percentage of your patients have had the colon cancer screening? They don't understand that it's kind of a work in progress for a lot of patients. I've been, some patients I've been counseling for a couple of years until they finally get it. All right, but that's a aside. So an EKG is a basic physical exam. You just want to listen for maybe heart murmurs or regular heartbeat. Remember, anything that puts strain on the heart can also lead to problems there. When you do an EKG, you're looking for something called hypertrophy, which is thickening of the wall of the heart, and that can also give me some evidence that, hey, this has been going on a while.
Is your pulse involved?
Yeah. I mean,
like, can you have a low pulse and have high blood pressure? You
can. A lot of people, though, we're in a kind of caffeinated, stressed out era here, so it's usually the opposite. Someone's just kind of got the pulse up and they're just kind of adrenaline's flowing, and that's more likely to do it. There are very good studies talking about things like meditation and biofeedback and what do they call it, mindfulness, and the ability of those interventions to lower your blood pressure and your pulse. Again, it's hard to measure, and it's hard to focus on. And Thomas will agree with me. The way I'm measured now is very results driven. What's my what's my patient's pressure? What's the pressure? So there's the idea that I'm trying to go through other routes other than the quick fix, which is medication. All right. That being said, medication is frequently necessary. So you also want to have some regular blood work. You want to have your kidneys checked. You want to have your cholesterol checked. Cholesterol is yet one more risk factor that kind of adds to the high blood pressure. In most cases, you want to have a glucose level check to be screened for diabetes. Diabetes is similar to high blood pressure in the sense that it is frequently without symptoms. Sometimes we will run some other tests like a thyroid test. And both an overactive and an underactive thyroid will raise your blood pressure. If the EKG is abnormal, I might order an echocardiogram, which is a kind of another way to look at the heart. Again, depending on the case, depending on the symptoms, I might even refer the patient to a cardiologist or a nephrologist. A nephrologist is a kidney specialist, but understanding that the kidneys have a major role in blood pressure, they are also frequently medical specialists that deal with challenging cases of high blood pressure. Thomas will know because they probably made him learn about these unusual conditions that increase your risk of high blood pressure, like adrenal problems. But those are what we call zebras in medicine, right? You remember the phrase I told you about?
If you hear hoof beats, think horses, not zebras.
Right. Did you hear that in your medical education?
No, it's very true.
So, you start kind of with the common things, so there are some unusual causes of high blood pressure. A lot of those can just be, the routine blood work kind of gives you clues about that, so if it's normal. All right, so if it's time to start medication, we start it. There's different choices. We sometimes something called a diuretic, which kind of gets you to excrete the extra fluid, kind of like letting a little steam out of the pipes, bringing the pressure down. Something called a beta blocker. Beta blocker kind of blocks your adrenaline. So your adrenaline makes the pulse go up, the blood pressure go up, so beta blockers kind of drop that. These things are called ACE inhibitors. Anything that ends in pril. A lot of people on meds like this, lisinopril, quinapril. These are very, very good medicines. And the reason they work is too complicated. I don't want to explain it. But the evidence that they protect your kidneys, not just bring your pressure down, but protect your kidneys and protect your heart from the risk of high blood pressure over time, important. And then there's something similar to them called ARBs, which end in tan, like losartan. Very similar medicines. Calcium channel blockers. A lot of people are on amlodipine or diltiazem. They work by dilating the blood vessels, and there's a few others. Anyway, but I guess to finish this subject, just understand that it's a silent condition. You should be checked for it on an annual basis. I think the evidence-based answer is about 35 or so, but I don't think it's a bad idea. I tell my patients, even the 30-year-olds, 25-year-olds, that come say hi to me once a year. They come in, because a lot of the roots of these problems can start earlier. Someone can start gaining weight, for example, at, between 25 and 30, that by the time they're 40, it can lead to high blood pressure or diabetes. So
once you're on these medications, is that it for you? You're on these forever?
That's a good question. Probably. But for example, if someone's overweight and they do lose 50 pounds, you're right. Maybe they don't need the medicine anymore. Also, sometimes as people get older, part of aging, that machine gets smaller. Body mass goes down. So it's not uncommon as a person gets older, to not require the same dose, or even be able to come off the medicine altogether. Yes, if there are other times where I would consider stopping the medication, but I do want people to do that in conjunction with their prescriber. I don't want people to be like, he's seen it. They come in for a blood pressure check. I'm like, your blood pressure's high. And they're like, well, that's because I stopped my medicine 6 months ago. Well, that's a little frustrating from my point of view, And then when I ask, why'd you stop your blood pressure? What do they say?
I feel fine.
Right, but the opposite. They'll say, I didn't like the way it made me feel. Uh-huh. I'm like, well, what happened? I don't know. It just made me feel weird. It's very subjective.
Right, so if you feel weird, you should call your doctor.
Right,
because,
right.
Like, as you said, there's all these different medicines that you could try. So if one makes you feel weird, maybe another one won't.
There are side effects. For example, these commonly prescribed ACE inhibitors cause a cough. What a weird side effect. Yeah. But they do. There's these very complicated chemicals in your body that kind of keep a cough in check, get kind of like unsupervised, and people can have this annoying cough from a medicine. It's always an unusual side effect.
So what you want to keep your blood pressure in those normal levels, the same way you want your blood work to be like in normal levels, right? And sometimes you need medicine to keep you at those normal levels because that reduces your risk of stroke or heart attack.
Right. That's right.
Okay.
Sometimes, patients are a little confused. I'll say, if I have a new patient, I'll look at the meds, and it has some blood pressure meds, and I'll just try to start a conversation saying, so you have high blood pressure? And the patient goes, no, it's not high anymore. Because they're a little confused. You still have it. It's just it's treated.
That's the medicine.
Right.
Which is the point, really.
Yeah. So take it seriously. Get routinely checked for it. If you do have it, it needs to be treated in some way. It doesn't necessarily have to be medication. We talked about other ways, but it still needs to be monitored. It can't be ignored.
Gotcha. Acute illness can cause your blood pressure to rise too.
Right, and then I worked urgent care yesterday, and I was like saying to the nurses, "What are you doing?" Are you scaring the patient before you check their blood pressure? But again, that's kind of the wrong place to check blood pressure because people are sick, people are anxious. But the other side of that coin is whatever. If this is someone who hasn't had theirs checked in a while, and you pick up on something and it points them in the right direction of proper care, it's okay.
Good.
You should have your blood pressure checked pretty much at all medical counters. Maybe I'll cut some slack to psychiatrists, but if you look at the guidelines, even psychiatrists are supposed to be checking some vital signs too.
What are the vital signs?
Oh, she's looking at you, Thomas.
So blood pressure, heart rate, pulse ox, so just like the amount of
we call it SAT.
Yeah, oxygen in your blood.
Right, which is kind of a newer vital sign.
Yeah.
And what amazing technology! You put this thing on the finger and it tells you your oxygen level. I don't know how it does it, but go on. What else?
Respiratory rate. So
respiratory
how
rate.
much you're breathing. How many times per minute.
And temperature.
Temperature, right? Yeah.
And you really should have a full set of vitals. That's what they're called, vital signs, for a reason, because they're considered essential to the evaluation of a patient. A controversial subject was when pain was thrown in as the fifth vital sign or the sixth vital sign, depending on how you commented. The problem with that is signs, kind of by definition, are things that are objective, that can be measured. I could check someone's pulse. I could check someone's temperature. So now that we're turning back the clock and we're seeing how problematic that was to call pain a vital sign, it was subjective to begin with. So that's a subject for a whole other time.
That's a big topic.
Big topic.
Mm-hmm.
That's our slogan for this show, by the way, Thomas.
Yeah.
Medical Mondays. That's a big topic.
That's a big topic.
You should really make those T-shirts.
Right. Well, look how big blood pressure got.
I know. So should I segue on to another subject?
Sure.
Okay. What?
Thomas and I can't wait to hear what
I guess we should talk about COVID, because it's still here. It's still relevant, still important.
I just heard driving here this morning on the radio that Dutchess County has a 6.2 rate and Ulster County is not too far behind. And they're talking about instilling new measures. Nobody wants to shut anything down again.
Right.
But in just taking these small measures again, they're talking about the distancing in restaurants, masking, and just moving forward more carefully because of the rise in cases.
Right. And it comes back to a bigger topic, which is the vaccinations. A couple basic points about the vaccine. One is, and maybe we're guilty of, maybe overselling. This is how we prevent you from getting sick. A lot of vaccines do prevent you from getting sick, but they don't always prevent you. They just mitigate the illness. So the flu shot, for example, most seasons the flu shot is anywhere from 60 to 75% effective. But in that remaining 20 to 40%, it can make the case a lot milder. And that's also true of the COVID vaccine. And part of the reason with the vaccine was to kind of get it out there and try to kind of stop the virus so it wouldn't mutate. And we did kind of miss that window with the Delta variant. And other shows we talked about it. I said, generally as something becomes more contagious, it becomes less virulent. Virulent is a word we use that kind of means just how bad something is. That's not really true of the Delta variant. I'd like to ask, one of our infectious disease colleagues what they think about this. The Delta variant is just as, and in some cases seems to be even more severe. So that makes this a little bit unusual. But our way out of this, still continues to be vaccination. A lot of places are starting to require vaccines. The president instituted some mandates basically last week for employees and federal employees and
Contractors.
Companies,
Contractors of federal contractors.
Federal contractors and with contracts with the government. I think even companies with greater than 100 employees, which is a lot of people. My organization is mandating by the end of the month. I did read an article, and I was going to pull it up about a OBGYN, a hospital upstate, up by Syracuse. Let me pull it up here. Let's see. There it is. Okay, so the headline is this came from CNN this morning or last night, but New York hospital to pause baby deliveries after resignations over COVID-19 vaccine mandate. So it's a hospital up in Lewis County, which is, I guess, in the Syracuse area, that had so many resignations of people in healthcare who didn't want to get the vaccine that they had to close their labor and delivery department. They had to pause it. They didn't want to close it. And we're struggling with this. As a doctor, I'm struggling with the resistance to the vaccine coming from my partners in healthcare, from nursing and other departments. So I find that very discouraging. And I know I might upset some nurses if anyone's listening, but really there's a lot of resistance from nursing regarding these vaccines. And I'm going to go so far as to say there really is something wrong with the nursing education if that's really what the outcome is. We have to. Something's got to be done. That being said, there's many nurses who embrace it. I got that urgent care, spoke to a nurse who works at Middletown Garnet Hospital who was in the ICU there, and she was there for a completely unrelated reason. But we talked about the vaccine and how firmly they supported it. At least amongst her friends and colleagues at the Garnet Hospital in Middletown. There was an article in the Freeman last week kind of saying that Dutchess County has, I think it said, the second highest rate of non-immunization at their hospitals. So Dutchess County has two hospitals, which is three I should say. Vassar and what used to be St. Francis, now is Mid-Hudson Regional, and Northern Dutchess Hospital. And the article went so far as to kind of say things were not as bad at the old St. Francis, but the rates were pretty low at Vassar and North Dutchess Hospital. So that's my organization. I think we got some work to do.
Why do you think there's, for me, this is a science issue. I know there's so much political backlash regarding this subject, makes people crazy. They dig their heels in because of political type reasons, but for me it's just more about the science and educating yourself. I'm not a scientist, I'm not a nurse, I'm not a doctor, but I educated myself, and honestly I've never educated myself about any other vaccine that I was given. I've been given all of them.
Right.
So I had a Tdap shot at my last physical. They said, okay, you're due for it, you need one of these. Tetanus, diphtheria, whooping cough, right? I don't want any of that. Really would rather not.
All 50 states have thorough and, similar immunization requirements for kids to attend school. And even a little controversy. We've talked about that. In the 90s, so when you and I were in school, and, the vaccines weren't that many. There was the MMR and the TPT and the polio, and that was pretty much it. And then in the 90s, they kind of exploded. The things that people may not even know about, but that we routinely vaccinate kids for: Prevnar, something called Haemophilus, the chickenpox vaccine, and then hepatitis B vaccine. There's a rotavirus vaccine. That's not required though, but the four that I mentioned all became required. And the hepatitis B vaccine, in particular, was a little controversial because part of the argument for polio or measles is that, fine, I may not get vaccinated, but if I get it, I can give it to you guys. So therefore, there was a public health measure. So hepatitis B is something that's not easily communicable in the air. It's a blood transmitted virus. Plus, it's also something that is really relevant for adulthood. So the idea that we were requiring the vaccine for kids to attend school for something that was going to be neither transmissible in school or relevant until they're adults was controversial. And I think it did kind of open the door up. And when you throw in some stories of bad reactions to some vaccines and then a controversial claim that it was linked to autism. So also remember that during this past 30 years, the sensitivity to diagnose autism and what they call spectrum disorders has also exploded. You know, they didn't even really teach me in medical school what Asperger's was. I remember hearing about it in my residency, and the psychiatrist I was working with kind of explaining to me that it was kind of social autism. So they didn't really teach it. And then, from the point of view of a parent with unfortunately with an autistic child kind of looking for a cause, something must have done this. We see that a lot with patients, something, must have made me sick. Something must have made my kid sick, and it's complicated. So some reports that have really been debunked linking vaccines to autism, but did kind of open up this door of an anti-vaccine movement. I've talked for a long time about how the non-vaccinators prior to COVID were frequently kind of highly educated people. We have a lot of them in Ulster County, in the Woodstock direction, in the Stone Ridge direction, in the New Paltz direction. And I was having a hard time coming up with another example of the link between being highly educated and then therefore ignorant about science. I can't think of another example in the history of humanity where people with education and resources chose to be ignorant about facts. Anyway, what else happened? The school districts were not the best at enforcing it. They were allowing religious exemptions for kind of religions that didn't really exist. And anyway, that kind of opened the door to this kind of anti-vaccine current. The flu shot, kind of being required, and then a lot of stories that I haven't even really brought the flu shot up much with patients because we're too busy talking about the COVID shot, which I guess if I'm going to prioritize is more relevant right now. But still, don't forget your flu shot. It's flu shot season now.
End of the month, right?
Now, September, October, November. And we're basically halfway through September, so now's a good time to get your flu shot. We didn't see much of a flu season last year, which was interesting.
Well, Eric, no one was near anyone else. Everyone was masked.
Correct.
And everything was shut down.
Except we still saw COVID, which tells you how much serious COVID is compared to the flu. How much more easily transmitted. Virulent. In other words, the flu, we were isolating and masking, so the flu wasn't getting around, but COVID still was. So anyway.
Still is.
What's that?
And still is.
Yes. By the way, I was behind a school bus this morning. Were you behind a school bus?
I didn't get behind a bus, thank goodness, but the kids were out waiting for the bus.
And how did that make you feel?
I loved it.
Yeah.
They were out, and they were all masked. They're all wearing their little masks, and so I actually was speaking to a professor from New Paltz, and
really?
And he said that I asked him how it was going. Interestingly enough, the kids are mandated to be vaccinated.
Right.
But the staff is not mandated to be vaccinated.
That's a problem.
I can't understand a lot of these.
It's probably some legal issues.
Rules. But anyway, so he said, the staff, to his knowledge, were vaccinated, even though there wasn't like this mandate. But he said the kids are doing whatever it takes to stay in school. Last year was so difficult for college students that they're like, wear a mask, stay far apart, we're fine. Like, we'll do whatever you say. We just don't want to not be in school. He's like, they're over and above compliant, happy to be compliant.
Yeah, I don't understand this argument that like the masks are so hard on kids. First of all, I see kids and they're fine. And by the way, I was a kid once, a while ago. I loved masks. That was Batman, Spider-Man. This is an adventure to put a mask on. This is cool. So I know kids are just fine with the mask, and they adapt well, and they follow instructions. The adults who are smoking 2 packs a day, they're having a rough time with the mask. But excuse me, but the kids are fine. We are.
We're at our next break. We'll be right back.
Okay, and thank you, Dr. Eric Stamberg, Robin Baker, and Thomas Richter, thank you so much for being with us today. And we'll continue after our break here. KCR is Kingston Community Radio, WGHQ, AM 920 and 92.5 FM. It's 7:59 right now, and it's Monday, September 13th, and 68 degrees here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Central Hudson. And we'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage, anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
Hey, hon, what you doing with your phone?
Do flowers have best friends?
I don't know. Hey, look.
Whoa.
Some answers can only be found in nature. Discover the unsearchable. Visit discovertheforest.org to find a trail near you. Brought to you by the United States Forest Service and the Ad Council.
Part-time job, full-time hustle, all-time Shiro to all of us. Now it's time for you, our Shiro, to stretch for the stars. Get free tips to help boost your retirement savings now at aceyourretirement.org/Shiro.
Brought to you by AARP and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And we're back. You're listening to WGHQ, AM 920 and 92.5 FM, the home of Kingston Community Radio. And my name is Dan Gatis, and it is 8:01 a.m., Monday, September 13th, and 68 degrees right now here in Uptown Kingston. And here's a little bit of Kingston and surrounding area weather and forecast. A mix of clouds and sun today with a high around 80. Tonight, that's a 40% chance of rain. Partly cloudy skies this evening, increasing clouds with periods of showers late. And low of 57. And Tuesday, mostly cloudy, a stray shower or thunderstorm possible. We've got about a 25% chance of that. And a high of 77 for Tuesday. Tuesday night, mostly cloudy skies with a low of 66. Same kind of 20% chance of rain for Tuesday. And Wednesday, partly to mostly cloudy with scattered showers and thunderstorms developing in the afternoon. A few storms might be severe, so that's going to be on Wednesday, and it's a high around 85. And Wednesday night, thunderstorms likely. We've got a 90% chance of thunderstorms likely, and a low of 64. This upcoming portion of Kingston Community Radio is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs. Discover the difference of buying local. Sales ongoing at herzogs.com. Now let's return back to the on-air studio with Dr. Eric Stamberg, Robin Baker, and Thomas Richter, and maybe birthdays.
All right. Welcome to the second hour. I am sorry to say we don't have birthdays. It is a very
empty folder.
It is a bare folder.
That should not be.
You want to wish anyone a happy birthday?
Yeah, I have a dear friend, Sean Schenker. He has the FSK Dojo out in Gardner. He's a musician, and he's a wonderful teacher, and has survived this last year of COVID. More resilience than I can say.
Like his was,
yes, shut down.
Yeah.
Shut down. And it's his birthday today, so happy birthday, Sean.
Happy birthday. To Sean as well. A great musician called the Traps.
Not
the Chaps?
Not the Chaps, but the Traps, and that's his band, yeah.
By the way, we were talking about things that kind of have a mind-body connection, the blood pressure and stuff, and certainly martial arts is also on the list, because they... I want to wish my brother a happy birthday on Friday. My brother, David, who will actually be next week's guest.
The real Dr. Stamberg.
Real Dr. Stamberg. He is now in the field of elder care and helping
families
and elderly patients kind of segue into a next chapter of their lives and how complicated that can be. And he's doing something that will be more relevant, and I think you and I will be customers in about
15 minutes.
All right, so just to finish COVID a little bit, a couple of anecdotes, and again, I think about this coming on the way in, how much, I don't want to, because we have to respect confidentiality, okay, but a patient of ours, Thomas, and I did a telemed visit on Monday or Tuesday in her early 40s, some health problems, nothing too major, not vaccinated, but we did a telemed. She had already been tested positive, I can't remember, for COVID, I can't remember when or where. But once you're really short of breath, you have not just COVID, you have COVID pneumonia. Now it gets a little complicated. Maybe you have asthma, and maybe the COVID is just exacerbating your asthma, similar to the way any other virus can be. But she sounded pretty bad. I can't remember whether it was a telephone or a telemed encounter. I advised her to go to the hospital, and she didn't want to. She asked me to prescribe some steroids for her, which I did. But 2 days later, she didn't get better, and she's admitted over at Northern Dutchess. And certainly, I wish her well. She did not get vaccinated, so I just want to say that for the record. So the vaccine doesn't always prevent the COVID, but when you look at who's hospitalized, who is seriously ill from COVID throughout our whole nation, around 90 to 95% of those patients are unvaccinated. So when people say they need more evidence, they need more research, I'm not sure what more you need, and then 650,000 deaths. I don't know what more evidence you need for that, and babies on ventilators. I just don't know what more evidence you're waiting for. So I wish this patient well. She's a nice person. It's the wrong time to have a debate, and then all you can do is check a website or go online. A lot of stories of people either dying from COVID or very sick with COVID, really trying to get the message out that they wish they had the vaccine. Unfortunately, there are some stories of people that even as they're dying. I remember reading about a doctor from South Dakota who taking care of dying people that even as they were dying, they were still kind of in denial about how serious this was and how upsetting that was for her.
It's very sad.
So it's very important that people get vaccinated. Anyone who works with this, still stories of elderly people who have AIDS, for example, at home, and the AIDS aren't vaccinated, and they bring the illness to the person. It's interesting the way it changed, because the elderly, we did a pretty good job of getting the elderly vaccinated pretty quickly. Most of them wanted it, lined up, So that's one of the reasons why we're seeing it kind of in middle-aged and younger people.
Let's just go over quickly before we end COVID, the criteria for being positive. And also let people know that there are home tests now. You can just get them at CVS or Walgreens, and it's kind of like a pregnancy test. It has one line
on the shelf.
One line you're negative, 2 lines you're positive. Yes, they're like 2 tests for $25 or something like that.
Really?
Yep.
Wow.
So there are those available.
That's quite affordable too.
And so what's the criteria though? But if you're positive, you have to. It's 10-day quarantine, right? If you're not symptomatic.
Right. Let's look at the test first, and they probably went over Thomas. The testing, the sensitivity and the specificity of any test. You want a test that's specific but also sensitive. So there's 2 tests, and they get used kind of interchangeably. One is the rapid test, and the other one's commonly referred to as the PCR, kind of the send-out. So the rapid test is rather specific. If it's positive, it's positive, it's positive. So generally, if you have a positive rapid test, you don't need to do the send-out. Would you agree with that?
Yep.
It's possible that the rapid test is maybe going to miss it, and because it's not as sensitive as the PCR, which is the send-out. The send-out takes about 2-3 days, depending on where it goes. So sometimes, if I'm still concerned, even though the rapid is negative, we'll also do a send-out because there's still a possibility. So that's one of the even though I think it's great that this test is widely available, I think that is probably the rapid test and still potentially missing some cases.
It is the
Right.
rapid test.
So, you know,
So if it's negative and you have some symptoms, you should probably reach out to your doctor for a PCR.
Right.
Okay. And then, so if you're positive but no symptoms.
Positive. You were, on the current recommendation, supposed to quarantine for 10 days from the date of the positive test. If you have symptoms, you quarantine from 10 days from the date of your first symptom. It gets a little complicated there because if 10 days passes and you're still not better, like our patient who had to get admitted, she was sick for a couple of weeks because people really deteriorate. You know, it takes 1 to 2 weeks frequently, you know, for them to get to that point. So I always say to a patient, 10 days, and you should be symptom-free. I say 3 days. There's some people might say 2 days, but, you know, and that's a general rule. And
Symptom-free.
Symptom-free.
All better.
All better.
Okay.
No fever, no shortness of breath, no cough, really back to your usual self. And then you can return to
regularly scheduled program.
Yeah, so I worked urgent care yesterday. We did have some positive cases. We had a couple people kind of positive, double positive, like for strep and COVID. You know, I'm wondering about that. You know, sometimes, you know, it just seems weird to have both things, but they did test positive. You know, you got to treat both at that point. Treatment as an outpatient is still kind of slugged around. The antibody treatment, which is commonly referred to the Regeneron treatment, is really an excellent treatment. Now, Regeneron's a company that makes it, so they make other products too. I still think that's an underutilized intervention for a couple of reasons.
Those are the monoclonal antibodies?
Yeah. Nuvance runs a program out of Vassar. So if I have a patient who's eligible for it on the EMR, I enter some orders that kind of go to this department that then kind of take it. And it's been working quite well. I think the problem with it is when the care is fragmented, you know, who's the provider who should be recommending and ordering this treatment is where it gets complicated. You know, so when my patient, you know, yes, you know, and you have to review the criteria. They've gotten more complicated. You know, age, underlying problems, BMI, your weight basically is a biggie, and actually it's quite low now. It's 25. Most people have a BMI greater than 25. Less than 25, I call that California thin. So that's not most of us. So almost everyone really is a candidate for this treatment if they test positive and it's within 10 days of the test or the onset of symptoms. So it's underutilized. Plus, there's also now a whole new criteria for people who haven't tested positive, but they were exposed, can also be candidates for this. What's happening is someone, for example, goes to CVS and gets the test and tests positive. What are they doing with that result? Are they quarantining themselves? Are they consulting with their physician? I think because this treatment now is particularly so broad as who's relevant for it, I think that you should contact your physician, ask for an appointment, probably a telemed appointment because, you know, you're supposed to be quarantining, and a discussion about whether or not this treatment's appropriate for you. I think when people receive the care at urgent cares, for example, where I was yesterday, it kind of becomes whose job is it now? Should we be telling these patients to call their primary today and whatever? And for that kind of fragmented care, it comes back to one of the themes of our show, which is the importance of
primary care
and a longitudinal care to help it rather than a fragmented care.
And one last thing before we jump from this subject, the booster shot.
The booster. It's there. It's being recommended. You know, I tell my patients, I read the news and, you know, watch headlines just like you do. Generally, yes, the booster is out and people are starting to get it. It seems to be 8 months after your last dose or your first dose, Thomas?
I think second. Yeah.
So you and I had my shots in January, so I should probably begin the process of looking into the booster. And think about it. If you go back to like February or March when the vaccine was out, but we couldn't get it. Patients were traveling to all parts of the state to get it, Plattsburgh and Binghamton. Where'd you have to go?
Margaretville.
That's
it's still an hour
more
away.
isolated than before.
It wasn't bad.
You drive an hour to get it.
Yeah. So I think it's kind of like that. Now we're rolling out the boosters. So I tell patients, yes, let's begin the process of getting it for you. But if it happens next week or even a couple weeks from now, so be it. But yes, you should get the booster. And we don't know. Maybe we'll have to get boosters every 6 months, 8 months until the pandemic wanes. I was thinking a lot about Dr. Froud. And when he came on the show, he talked about the Russian flu epidemic of 1898. Thomas and I were reading about this last week. And when they studied this infection, it was felt to be a flu for a long time. But when they look at the genome, and don't ask me how they even get to it, it must be stored somewhere. It turns out it's a coronavirus. So Dr. Frau was making the point that if you look at this pandemic in 1898, you can get clues as to how this is going to kind of pan out. And unfortunately, it took a couple of years, a couple cycles, So I think we're in for kind of a, like a 3-year. The good news is we're about halfway through it, And
historically.
We had tools now that they didn't have in 1898. They didn't have vaccines, for example. Another interesting historical fact was that George Washington required the Revolutionary Army to have smallpox vaccines. So it gives you a couple of important points. How old the technology is, for people who go, I don't know what's in it. I don't know what's in it. It's not new science. George Washington got it. I don't think you get more American than that. So when people say this required vaccine thing is infringing on our rights or whatever, you could take it up with the ghost of George. He got the message. In those days, general health wasn't great, and the health of soldiers wasn't great. They were much more likely to die of disease than they were of any
combat.
Yeah, combat or
Yeah, that smallpox vaccine is a very, very, very very interesting story.
Yeah.
Irish milkmaids were immune to smallpox.
Okay.
And that was because of a certain antibody that they were getting from the milk.
Interesting. Kind of that's a different type of immunity.
Science.
Similar to what a breastfeeding mom can give to their baby. All right. So we should bring some finality to our COVID discussion. If you have not been vaccinated, please, 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 please consider it. Get it. I think people are kind of coming around. Some people are forced to get it by their jobs, and I'm like, good. Maybe if, I don't know, my job didn't force me to get a flu shot, maybe, as a physician, maybe I would be negligent, forget to get it, that type of thing. So sometimes the prodding is what it takes.
I don't know, I just have one comment. I just feel like we're really not allowed to get other people sick. Like it really should just be a common sense, a common man, woman thing. Like
citizen.
A citizen.
Of our.
I know a lot of people that smoke. I have some very, very dear friends of mine that smoke. They're not allowed to smoke by me.
Right.
They have to go to a special designated area. They have to smoke somewhere away from me. They're not allowed to smoke next to me. Right. And they don't. They don't even think twice about it. They don't question it. They just go to where they would like to smoke. It's their choice. They feel like smoking. Good. They can go smoke. It's and that's okay. But they're not allowed to.
By the way, that
sick.
Was an argument when that didn't happen that long ago.
No.
Probably about 20 years where they started to ban smoking from bars, and
right.
that was infringing on our rights to smoke.
Right, because they found out it was harmful.
Right.
They knew it was harmful, but they proved it was harmful, and then they stopped allowing other people to hurt other people. Right. They didn't stop people from hurting themselves if they wanted to, But
another analogy is to things like seatbelt laws and motorcycle helmets. The argument there was, first of all, we don't want people to get seriously injured, but harm is measured in different ways. If someone, has a bad car accident, they might require, medical care for the rest of their life, and that has a cost attached to it, and we have to pay for it. And I know that's kind of a cynical way because people go, oh, all we care about is money, blah, blah, blah. But you know what? We have a facility right in our community, the Northeast Center for Special Care. That's what they do. They take care of patients chronically injured and things like that. So the idea of public health is not new. George Washington got it in whatever year that was. We figured it out in beginning the late 1800s that things like water supply was important. And New York had great history of reservoirs and getting adequate water to a big city, and how that improved the health of people overall. And then the beginning of modern immunization probably began with, I guess, the famous polio vaccine. And stories of families in Brooklyn and other cities lining up to have their kids vaccinated. So anyway, please get vaccinated. And if you want to discuss your rights, right.
What kind of rights do you have in your life if you're laying in a hospital bed, prone, with a ventilator? What rights do you have at that moment?
I've read a little bit. I've heard a little bit about people saying, well, if you're not vaccinated, we should take care of the vaccinated first. It's your fault. As a physician, we don't like that. That's like saying to someone, hey, we're not going to take care of your lung cancer because you chose or you continued to smoke even though we told you not to. And that even though there's a temptation and you want to say, when I covered the hospital, I'm the one who has to admit the patient at 3 a.m. There's kind of like...
no, you're taking care of them.
Right.
It doesn't matter the reason.
No, it did. And, I always, whenever you hear about a horrible, like a criminal, for example, who winds up shot in a shootout with police or whatever. I mean, what it must be like for those surgeons and who now have to take that person to the OR. I'm sure there's similar feelings. But, man, oh, gosh. I just lumped unvaccinated people in with,
no.
with criminals. But
that's not true.
The point is that in medicine, we don't want to judge who we take care of. We want to just take care of, not to say we have our feelings, but we're not going to let those overtake us. So the argument that unvaccinated people should kind of be last in line, it doesn't really work with our standards.
No.
Agree with that?
No.
All right. So we wanted to talk a little bit about Thomas and I. It's not unusual for people to have a Medicare Advantage plan these days. This was an idea, came up about 2005, 2006. The idea that a private company was going to do a better job of managing healthcare dollars than the government. So we were going to hire these companies to take over managing Medicare patients. If you look at the actual numbers, these companies were paid more to somehow cost less. So when I was in private practice in Rosendale, say I provided a service that Medicare paid me $75 for. Well, now they would hire a company that would pay them $100. That company would then pay me maybe $75, maybe $80, maybe $60, and then somehow pocket the rest and in the big picture do a better job, and therefore it would cost everyone less. And, so that's been out about 15 years. And, how do you think that's going?
Not too good.
Not too good. And the way the government decides how much to pay these companies to take care of these patients, depends on how sick they are. Right? And that makes sense in a way. You and I know 65, 66-year-old people that are healthier than me. They go to the gym. You know what I mean? They're that's not the same as someone who's, older with other health problems or whatever. But that gives this kind of incentive for these companies to make their patients sicker, sound sicker. So it's not unusual for people with Medicare Advantage plans to have nurse practitioners come into their home to do a visit. And this is always something that kind of confused me and troubled me a little bit. I was trying to figure out what exactly is going on here. It's kind of like almost like a shadow healthcare system. I'm doing what I'm doing, but they're kind of doing something in the background. And from the patient's point of view, it's no big deal. They say it's for your health, whatever. And I don't fault the patient. Some patients are like, I'm not. I told them to take a hike, doc. You're my doctor. Other patients are like, they offered to come. I said, whatever. I wasn't doing anything that morning anyway. They produce a report from the visit. I don't always get the report, but the report, when I get it, it's usually kind of that computer-generated drivel. That's just not helpful. I mean, so that notion that somehow they're providing information to me is not good. Is it possible that they're going to tell someone that you should get a mammogram, and that person's going to then follow through on something that I ordered? I guess so. You could argue that. But so what are they doing there? What exactly are they? They're spending money on that, right? They're hiring nurse practitioners to go in the community and spend an hour or two with someone in their home. Well, they're doing two things. One is to, encourage people to get appropriate preventative measures and health care, which I guess is good, although it's a little redundant. And they're also coming up with ways to make sure that the patient is as sick as they seem. So therefore they get more money from Medicare. They want an accurate summation of the patient's health care to submit it. So they have a motive. Does that make sense the way I'm describing it?
It's a little confusing. And I can see if you're an elderly person and you're getting these calls, it would be confusing to me.
Right.
I find in general people have a hard time understanding their insurance anyway.
Right. And this is presented as a service. And in a way it is. But the motive, is a little duplicitous. They want people to, they're trying to make you seem sicker. They're making sure that they're not missing something. Maybe you have not just diabetes, but maybe you have diabetes with a circulation problem. So, that's the way Medicare measures it. Well, a diabetic is worth this much. I'm putting that in quotes. A diabetic with nerve problems is worth this much. So they're kind of making sure that everything is counted, so then they can make you seem sicker to Medicare, who will then pay them more to take care of you.
But when you say seem sicker, it makes it sound like they're not telling the truth. So
that's a good point. Maybe I should stop short of accusing them of padding the record. I guess they're just doing it. They're just doing it for their own self-interest. Is the best way to kind of sum it up. And I don't like it because I think I wish I had more resources, to do it. And then I feel that's just an unnecessary, a redundant service. But it also draws light on the whole Medicare Advantage project. When patients say to me, well, should I sign up for something? I say, well, pay attention to the second word, advantage. What's the advantage to you? What is it? What are you getting out of the deal? And sometimes it's something, well, I'm getting my eyeglasses covered. I'm like, okay, I guess that's worth something to you. But it's a little bit of a deal with the devil. You got to play by their rules. You got to use doctors that are on the system. Some companies, I guess I should not mention them, but one in particular that has a pretty big employer in our community, does a pretty bad job of signing up specialists to provide care to their patients.
Right. Our listening audience, how often do you call a doctor and you're told we don't participate with your insurance?
Right.
You can't come here. How often does it happen to you that you've had a patient for 20 years that they change insurance and now you can't be their doctor anymore? It's not dictated by what the patient wants. It's dictated by the insurance company and what's getting paid for.
It's very hard for me to take care of someone. I say, hey, you need to have a colonoscopy. I'm going to refer you to this doctor. And then I get a call late in the day saying, well, he doesn't accept your insurance. To kind of play this.
Can you send me to somebody who does accept my insurance?
Right. At some point I say, you got to call your insurance and find out who they got because I'm running out of options here. So, and there's a very simple reason why there are not many doctors signed up for this plan. Do you know what that reason is?
They don't pay it very much.
Pay. So, so remember, the government's paying more to these companies to somehow use less money. Well, how are they going to use less money? They're going to try to get providers in contracts where they pay less. They're going to ration care, make it harder to get certain things like imaging or jump through more hoops to get certain interventions done.
Even this basic conversation makes patients wary. It's like, who can they trust?
Well, it just seems like in retrospect, I can't believe the idea kind of sold in 2006 or whenever it was. I mean, looking back 15 years, it just doesn't make sense, that we're going to charge someone more to ultimately cost less.
To me, it's a little bit of semantics. Like, you don't want socialized medicine. You don't want socialized medicine, except you accept socialized medicine.
Right. And we, in a way, that's kind of the American way. There's kind of, we have it, but we don't. That's why we kind of awkwardly try to include private companies, because it makes us feel better that we're not quite going down the socialized route altogether. All right, we're going to go to our last break of the morning.
Thank you, Dr. Eric Stamberg, Robin Baker, and our guest for today, Thomas Richter, medical student, fourth year medical student. And we're now all at the bottom of the hour and with us on Kingston Community Radio, KCR at AM 920 and 92.5 FM, WGHQ, and live streaming on mykcr.org. It's Monday, September 13th, and 65 degrees. It seems to have dropped a little bit over the course of the last couple hours. And this last portion of Kingston Community Radio has been brought to you by Herzog's. Because the colors and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center also provides color samples from Benjamin Moore paints, including the eco-friendly Aura line. Color decorating consultants and expert interior designers are ready to assist you in choosing the right colors. Visit Herzog's in the Kingston Plaza. And we'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Hey, I'm Haley Kiyoko, and I know what it's like to struggle with mental health issues. If you have a friend that's going through a tough time, now is the perfect moment to reach out. Learn how to start the conversation at seizetheawkward.org.
Brought to you by the Ad Council, the American Foundation for Suicide Prevention, and the JED Foundation.
Okay, forest animals, kids are coming to the forest, and it's up to us to make their visit a good one. Sparrow, have you practiced the most popular bird songs for the year?
Of course.
Catchy. I like it. River, how's the temperature?
It's a refreshing 52 degrees, man.
I love it. Turtle.
He's not here yet, man.
He's late every morning. Okay. Squirrel.
The forest has been preparing just for you. To learn more about cool things to do in the forest, visit discovertheforest.org. Brought to you by the U.S. Forest Service and the Ad Council.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you and support KCR.
And you're with us back here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. The weather again one more time. We've got a mix of clouds and sun today with a high around 80. Nice and sunny today right now. And tonight, partly cloudy skies this evening with a 40% chance of showers later tonight and a low of 57 degrees. And then on Tuesday, mostly cloudy. A stray shower or thunderstorm is possible with about a 20% chance of rain with a high of 77 on Tuesday. And Tuesday night, mostly cloudy skies, a low of 66 with that same nagging 20% chance of a possible shower or thunderstorm. And then Wednesday day, partly to mostly cloudy with scattered showers and thunderstorms developing in the afternoon, about a 50% chance. A few storms might be severe. It's a high of 85 on Wednesday, and then Wednesday night, thunderstorms likely. It's a 90% chance of thunderstorms Wednesday night with a low of 64. And let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Well, let's get back with Dr. Eric Stamberg, Robin Baker, and our guest today, Thomas Richter. Welcome back.
I forget what.
All right, good morning. Welcome to the final half hour of this morning's show. We've had a very invigorating discussion, haven't we?
It's been, yeah.
If I say so myself.
Yeah.
You still got 30 minutes to call if you want, 331-9255. I was telling, Thomas is my witness. We had 3 or 4 people in the office kind of mention our show recently, so people are listening. And, what's the story I like to tell? Should I tell the story?
Can you reintroduce Thomas to the audience? Maybe somebody joined a little late.
Thomas is a fourth-year Thomas Richter. He's a fourth-year medical student from Toro Medical College, which is in Middletown, and he has decided he wants to be a radiologist. So he's beginning the process of trying to match. That's the word we use. It's an interesting system because it's been around since the 40s. Yeah. The idea of matching medical students to residency spots. You also do a transitional year, right?
Yeah, I'll have to do one.
So, and that's not always at the same place.
What does that mean?
So, I don't know why, but there's it's kind of an outdated system. But there's some 4 or 5 maybe. So radiology, I think dermatology is one. Anesthesia. It's just random ones. But they make you do basically a year before you start actually doing whatever it is, radiology or dermatology. Right. You do a year of just internal medicine, for example, or just surgery, or a transitional year, which is just kind of doing random things in medicine. I don't know why it's a precursor year, basically, but you have to apply separately, which is kind of
right, and that's unfortunate because then you could potentially have to go to one town for a year and then you got to go to another town, So ideally, you want to wind up in the same place that you can do your transitional year and then the rest of your residency. Yeah.
As a student, are you still paying for your residency?
No, so that's just medical school. So apparently we will get paid in residency.
Yeah, they do get paid in residency.
That's probably a good topic for another day.
Well, I get a little cynical here. I was telling Thomas, I don't know. I'm not so sure if I should go there or there.
It's like being an apprentice.
What?
Are you being an apprentice?
Yeah, kind of. You're a half an adult. Yeah. You're a doctor, but you're not ready. You're not allowed to practice unsupervised, and it just shows you how long the road is.
So, how many years in school is it for you to become when you will be finished?
So, 4 years of medical school, and then obviously before that, you do 4 years of undergraduate, and then you would have to do your residency, depending on what you do. So, mine will be 5 years,
including the transitional year.
Which is one of the more lengthy ones.
So 5 years from now?
5 years from now, 5.5, I will be practicing attending.
Right, and he'll be 56.
Right.
He'll be 56 years old. And then you can even do a fellowship beyond that.
Yeah.
My family practice is only a 3-year program, and if someone said that, does that make sense? I'm like, no, it should be a 4-year program. Even there's so much to learn. Every now and then, there's some article saying maybe it should be shorter. I'm like, what are you nuts? Do you have any idea of what we're doing? Because you clearly don't. But it's a long road. Yeah, one of the arguments of the U.S. system versus the European system. The European system. College is usually medical school, so these kids kind of graduate their high school or whatever age, and they go to university, which can be a medical university. So that's one of the things that makes our system more expensive than other systems is that we kind of have an undergrad and then a medical school. And so one of the arguments is always well, maybe you shouldn't have to go to undergrad. Well, I think the amount of education you go through in an undergrad is also valuable as well. So. And it is what it is. I don't think that's going to change.
And I think it's important that the listening audience also knows that doctors don't stop learning. In fact, they are required to still
That's why they call it the practice of medicine, because someday I hope to be good enough.
But what is required of you? I mean, you have to continue learning. And I think a lot of professions you continue to be tested as well. You have to pass your boards.
Right. In fact, I am up for my boards next year. So, which I used to not be so nervous about these things, but as time goes on, I've gotten further away. But I'm looking forward to some good old-fashioned, learning and reinforcing some principles. You got to take the boards, and there was a time where being board certified was kind of an option. It was kind of like an extra kind of thing to put on your on your placard that you were board certified. But as time went on, the option became kind of a requirement. So you really have to be board certified in whatever field in order to be able to practice.
Yep.
And it's always, again, not without controversy. You know, the road is long enough and expensive enough. So board certification is yet one more thing. It's an exam that has to be paid for, and it's not cheap. You know, so it just adds to the price tag of having to practice medicine. You know, he has to, in addition to going to medical school, he has to take his USMLE. Mm-hmm. You know, which is to be licensed, United States Medical Licensing Exam. Is it still a 3-part exam?
Yeah, 3 parts.
And again, you know, it's something you have to pay for. Where do you have to go to take this?
They offer it like Prometric centers, is what they call it. So
that's a little bit different now.
Yeah, so kind of wherever they are. So I mean, there was one in Pittsburgh, thankfully, but I know people who are living maybe middle of nowhere and they have to drive like 3 hours to go, so.
And then you have to maybe stay over, but it just, the cost, that these kids now have to pay. How much is the exam?
I think it was like $750.
$750 to take this exam. It's probably about, $150 when I took it, So it's a lot of money. They're young. He's already in debt. They just the price tag keeps going up. So that's unfortunate. What do we want to finish the show with? I wanted to talk about etiquette again. I think it's always a worthwhile theme, and I think people actually like to talk about it because, 15 minutes or so. But people are frustrated with the doctor's office. Would you agree with that statement?
Yes.
And sometimes I feel like, in a busy day, a dark day, I'm like, gosh, is anyone happy in this system? Because we're all under strain. The doctor's off, the patients are frustrated, the staff is frustrated, the doctor or provider's frustrated. So there really is a need for just etiquette. How are we going to interact with each other in a way that's going to make this as workable as possible?
There was a posting this past week I read of a woman who I knew quite well who used to work in Ellenville. They've since moved to Florida, and she's a administrator in a hospital down there. And they had to put a big sign in their lobby saying that they would be patients who couldn't have etiquette would be removed from the hospital. Can't use foul language, can't, act in a disruptive manner.
Yeah.
I mean, they found it's like as tall as a person.
Yeah.
This poster that they had to put up in their lobby of their hospital.
Right.
So, and I find it interesting because I work in a doctor's office, how people have patients in other places and they don't have patients in the doctor's office.
Yeah, can I tell my story?
You'll stand in line at CVS.
CVS.
For your prescription, they're understaffed, they're overworked, they're trying to get to people as fast as they can.
I tried to call my garbage company last week, and the message said that you're 20th in line.
You're 20th.
You're 20th for my garbage company.
And did you wait on hold, or did you just
No, I did, and then I ran out of time because I had to go do something.
Right.
So I'll try again tomorrow when I.
But at the doctor's office, even your experience yesterday at urgent care. If you go to urgent care, you expect to wait. You're going to urgent care. But if you have an appointment with your doctor and it's 3:30 and it's 3:45 and you haven't been brought back to the room yet, I mean, I'm asking you to not be upset. Like nobody is wanting you to wait, and no one is sitting with their feet up somewhere. Right. Everyone's really diligently trying hard to make sure that they stay on time, that you are on time, that your time is not wasted. Of course your time is valuable. I hear that all the time. Well, my time is valuable too. Of course it is. No one thinks it's not.
Right.
But for some reason in this venue, it's okay for the person to get more upset than they would in any other capacity. It doesn't really make much sense.
Right, it's complicated. I had a couple incidents where the message was sort of like, I want to call back. If not, I'm going to come right down. I'm going to come down there. Is that a threat? What exactly is going on? You're going to, and in general, I don't recommend you do that to your doctor's offices, at least your primary care offices. don't come down, don't really kind of walk in, go through the proper measures. And yeah, it's not an efficient system. It's a very inefficient system. I was just talking to you about this healthcare companies having a shadow healthcare system, complicating things. And the job has gotten harder. There's more phone calls. There's more to do. There's more meds to prescribe. There's more tests to order. There's more authorizations that have to go through. As one of the earliest themes you and I had on the show, which was, we talked about triangulation, doctor, patient, insurance company, 3 points, and how dysfunctional that relationship could be. Any therapist will talk to you about triangulation, and how frequently the doctor and the patient are kind of pitted against each other. So if the insurance company, for example, is requiring an authorization, and that authorization is taking some time, is it the doctor's fault? Remember, I already prescribed the medicine. I've already authorized it. It's this crazy system that's now saying to me, you have to authorize it a second time, and then this time by our rules. And if we don't agree, prove it. And if we don't agree, you're going to have to do something else. And so that can be very frustrating to patients. And the patient can have the walk away with the impression that somehow I'm standing in the way of their care, when I absolutely am not. Remember, I prescribed it to begin with. Right? You always say that. Mm-hmm. I didn't prescribe you this diabetes medicine because I did not want you to have it. I prescribed you this medicine because I wanted you to have it. So we just need better etiquette. I mean, it seems to maybe be part of a bigger problem, a lot of anecdotally, kind of in this COVID era, people not behaving as well, whether it's outwardly being, about the masking or whatever, or just kind of not being well behaved at a restaurant or anywhere else. I mean, just really a call for more congeniality, amongst us.
Yeah. Thomas, what do you think the business of medicine, as you've been going from specialty to specialty?
It's very different in every system that you're in, In family medicine, there's a lot, like you were saying, a lot more hoops and stuff you might have to go through, which is really challenging for both the patient and the physician. Maybe in the emergency medicine setting, it's you don't have the right insurance, and you're going to get a huge bill, So there's a lot of different factors about where you are, and there's a lot of hoops and balances you have to go for everything,
I mean, a specialty office usually has more staff, so they kind of have, I use the word infrastructure, an infrastructure to get a test approved or whatever. A lot of times in primary care, maybe someone needs an MRI, like a shoulder, for example. I usually am a little reluctant to order it because it could frequently turn into the insurance company might disagree or just kind of say no, and then they want me to make a case. They like to do what's called peer-to-peer reviews. Get on the phone with someone and, in the middle of a busy day and wait on hold and if their argument is that they want that MRI shoulder be ordered by an orthopedist, I'll refer the patient to an orthopedist. It does affect the way I work things up sometimes. So we talked about sleep studies. Actually, sleep studies have gotten a little bit easier to order, but a lot of people have sleep problems and it's underdiagnosed, and there's really not nearly enough sleep specialists to handle this. So it's not, it's pretty common for it to come up in a physical or whatever, and the fact that someone needs a sleep study, but it can be very difficult to order in the primary care setting. It has gotten a little bit better.
I think the one part of being a doctor, the business of being a doctor, that's very confusing, and I think it's hard on patients too, but it's really hard on doctors. Doctors who are just people too, honestly. I mean, they're very well educated, but they're just people too. There's this conundrum, or I find it's ironic, that if you need, let's say, a handicap parking pass, or you need an excuse from work, or if you need someone to vouch for you,
right?
It's your doctor. Your doctor tells the truth. Your doctor says what it is, and work is not going to accept you saying you were sick. They will only accept a note from your doctor. The DMV doesn't think you can say whether you're handicapped or not, you need a note from your doctor.
Right.
But when it comes to ordering things like medications or tests or going to a
all of a sudden my
specialist,
note's not good enough.
all of a sudden,
Yeah.
the doctor is being questioned
Right.
and is being asked to prove it over and
Interesting,
over
right.
again.
Interesting.
It doesn't make any sense.
It's a little contradictory, isn't it?
It certainly is. And it's rough on patients and it's rough on doctors. That's that whole idea. Being good enough in this way, not being good enough in the other way.
It came up a little bit yesterday with in the urgent care setting, people are ill, and they sometimes ask for notes for work, and two problems arise. One is I really don't know for sure when they're going to be better to go back to work. I'm really just kind of pulling it out of the air. Yeah, we're not talking COVID. We're talking about like just someone with bronchitis or something. And the other reason is I also can't violate the confidentiality of the patient. I can't sit there and go, the patient, is ill with pneumonia. They will not be able to work because that's the PHI. That's protective health information. So it really can make writing a basic work note quite challenging.
Right. You have to say illness or injury.
Right.
Vague.
And I'll explain to the patient. Sometimes when it's COVID, I'll say to the patient, because in a way, I can give the patient the note, and they could, but I can't like fax something directly over to the employer. That comes up a lot too sometimes. I could say, you want me to put this in a note, fine, but you can come pick it up because it's your health information, and if you choose to disperse it, that's fine. But I can't disperse it. It gets complicated. So it's another example of how things have gotten more complicated with the privacy and HIPAA. And we're, I always joke, only half joking, that I have the only, this job where I can't even acknowledge my own customers. Hey, see someone in a restaurant. Robin's like, who is that guy? I'm like, oh, just some guy.
I don't know.
Yeah. Right? It's weird. Of course he comes to the office. He has a doctor. Most people have a doctor. It's confusing and complicated.
So just in the subject of etiquette, just keep that in mind.
Yes.
That, the doctor, is up against a lot of obstacles as well. And that we're on your side. I say that all the time.
We are on your side.
I answer hundreds of phone calls every day, and I get a lot of people who are angry and upset about one thing or another. But it's always starts somewhere. It's like, okay, let me see why your medication didn't get to the pharmacy.
Right.
Let me see why it didn't get covered. Let me get you to the person that's going to be able to help you. I mean, all the patient knows is that something went wrong.
But some of that is fed in by the insurance business. They'll send the patient a letter. We are unable to improve this whatever medication because your doctor did not give us the appropriate information. They're clearly throwing it back at me. So it could be. I think the cynical side of me thinks it's a little intentional. Remember, they want to go in and do their own healthcare evaluations. So it's complicated. But please be nice. But by the way, etiquette is a two-way street. You're right. We have to be nice back. We have to do our best to respond to our patients' needs.
Right.
So, and that might be at least the roots of it. Stories of patients going to a doctor and waiting for an hour or two, that kind of notion that they're not being respected or valued, well before COVID, it might be the kind of the roots of this dissatisfaction with their healthcare provider. So it's complicated.
Yeah, things got bigger.
But etiquette is a good word. Doctor-patient etiquette. We go over some basic rules. Thomas has heard me say this. I should come up with like a 10 commandments of doctor-patient etiquette. One for the doctors and one for the patient. For the patient, don't tell the doctor what your diagnosis is. Don't tell the doctor what treatment you need. In other words, don't go in and say, I have a sinus infection, I need an antibiotic. Don't do that. You don't go into the mechanic and say, I need a new, it's making a noise, I need a carburetor. No, you go in and you say, it's making a noise, figure it out. So you go in and you say, I've been feeling ill for the past 2 weeks with nasal congestion and, whatever. So that's kind of rule number one. Don't say what you need. I hurt my back and need an MRI. Well, Don't do that. And it's okay.
Well, let's talk about it,
Right. And I'm okay with, I know this is an information age. I'm okay with people reading and doing their own research. I wanted, one thing I wanted to mention quickly before the show ends was, we didn't mention during our COVID section was ivermectin, because it does kind of tie into this, because I don't think I handled this well. I did have a patient last week, Thomas was there, who wanted ivermectin prescribed to her to prevent her from getting COVID. And he said it was also prescribed to her husband by another physician. The same individual did not want to get the vaccine, so already we're kind of contradictions. If you don't want to get COVID, get the vaccine. Why? But I did my own research on ivermectin. My own research. I sound like a patient, but ivermectin is a anti-parasitic medication. It has a role in veterinary and parasitic illnesses. It actually is on the list of treatments for lice for humans and some other unusual problems. I'm not quite sure why they think it might have effectiveness against COVID, but it is being studied. It might be a big wash. Remember, a year ago, we were having this discussion about hydroxychloroquine, and I remember saying at this table, I don't know why they think this is going to work on the virus, and it turns out to not been effective. So what I should have said to that patient, Thomas, was that, it's really not right to prescribe to you. It is true that it's being studied, and maybe it will become something that's of value. But right now, that's not the right treatment. Instead, I got, I think, a little, up in arms about it, and so I regret doing that. The patient said something like, "Well, there's two different opinions," and I was like, "Well," so anyway. If it comes up again, that will be my answer.
Right. Well, it comes back to that science thing.
Science.
Oh, yeah, that.
What's the song we liked in the 80s? Science. Well, all right. So Ed, we talked about it. I think we covered everything here. We got to finish the show with something.
Well, can we talk about Lyme real quick?
Okay. Actually, I had an article about Lyme right here.
Yeah, I had a real good friend of mine who came down with like vertigo and she's migraine, and she's just so sick, and they were having such a terrible time. And it turns out she had Lyme.
Yeah. And
she went on antibiotics, and it's like miracle, she's better. She's
on
just
IV or pills?
Just oral.
Yeah. When I diagnose Lyme, I always say to the patient, the great majority of cases of Lyme are easily diagnosed and easily treated. And first of all, it's true. It's not an unfactual statement. But it also, I'm trying to divert them from going down the chronic Lyme pathway. There's an example. She was quite ill, and once the diagnosis was made, she got better.
Mm-hmm. And something like vertigo, until you get it, you don't realize like how terrible it is. And then, the doctors were having such a terrible time trying to help her, what medications to give her, and like nothing was helping.
Finally, someone did a Lyme test.
Well, I guess it takes, you're sick, so they do blood tests, and it takes a few days for the blood test to come back. And while you're waiting for that blood test to come back, you're sick. So, but yeah.
So that's a good take home, though. Eventually, the diagnosis was made correctly. Eventually, the treatment was instituted, and she's doing fine. So the whole idea of chronic Lyme is such a big topic. See, that's our T-shirt. Most people will tell you it doesn't exist. Now, there are doctors out there, we got 1 minute left, doctors out there who kind of believe in that, and some of them are rather quite local, and Rhinebeck, maybe they'll be vindicated in the long run. But right now, they're not. And they're outliers, and they also usually don't accept insurance. It costs a lot of money to just walk through the door, and I think you should be suspicious of that. That's my opinion.
So there's also with the Lyme, you could get other Lyme, tick-based illnesses, yes. Right? Not just Lyme. There's like other ones, right?
There's kind of four, right? Lyme is one, and then there's two that are very closely related: anaplasmosis and ehrlichiosis. Those don't cause chronic problems. They can make you quite sick, but they don't. Undiagnosed Lyme can lead to like knee problems, heart problems, and neurologic problems. And then there's something called babesiosis, which is also different. We had a patient, I don't know if you were there. Anyway, we'll have to revisit this next week.
It was a wonderful show, Thomas. Thank you for joining us.
Thomas, thanks for joining us. Thanks, Dan. And next week, we'll be talking about a lot of elder-related issues.
Excellent. Thank you, Dr. Eric Stamberg, Robin Baker, and our special guest today, Thomas Richter, a medical student, 4th year, Truro College. And thank you for being with us here at KCR, Kingston Community Radio, on this Monday, September 13th. 66 degrees here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, locations near you. And we invite you to keep up with us and be with us tomorrow at 7 a.m. till 9 a.m. and every weekday. And until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.
Yeah, I was about to say.